mentioned his name a few times. Our presenter is Dr. Dave Ingelthaler. He is the co-director and associate professor of the Pathogen Genomics Division at TGen North in Flagstaff. TGen North focuses on pathogen genomics with a specific mission to advance clinical medicine, public health, and biodefense, safeguarding our community against outbreaks like COVID-19. His team was involved with Ebola, and the team there early on was involved with the anthrax. So I'm not sure, Dave, if I've stolen your thunder in any regard, but I know you'll touch on some of it and go into detail where it's needed. Just a little bit about Dave. Prior to joining TGen, he was the state epidemiologist for Arizona at the Arizona Department of Health Services, where he was responsible for coordinating outbreak investigations and disease research activities statewide. He leads TGen's collaboration with the state of Arizona in response to COVID-19. And this morning, he's going to be talking specifically about COVID-19 and a little bit about the work that's taking place beyond that. And just in terms of business, we have less time for questions, so I encourage you to use the chat feature at the end, and we'll be going through those questions and fielding them for Dave. So with that, I'm going to turn the program over to Dave, and just again, thank you all for being on the call this morning.
Great, thank you, Erin. It's a great introduction, and I'm totally thrilled to be able to talk with the TGen ambassadors. This is such an important group for TGen. You guys know we do a lot of amazing and exciting work at TGen, and I know that you guys are our champions, and we're here trying to make as big an impact as possible. The COVID-19 has really provided that I guess that backdrop for us to make an even bigger impact. And so I do want to talk a little bit about what we've been doing at TGen and TGen North specifically, and then also certainly dive into COVID, some background on COVID, what we're learning, as well as what TGen is doing in this realm too. And then we'll certainly try to leave as much time for questions, because that's where I really want to spend time. But I was grateful for Dean telling me that I can go ahead and talk a bit about what we had been doing up until this point. So really before COVID, TGen has been in this genomic first responder role for quite some time. We have a 13-year history in public health and public safety, solving disease outbreaks, participating in disease outbreak investigations locally in our backyard, across the state, with multiple tribes across the country and around the globe. And you heard about some of the things we've worked on. We solved some of the larger disease outbreaks of our time before COVID. The massive cholera outbreak in Haiti after the earthquake, we were able to solve that here with scientists at TGen North. And I'm going to talk about a couple of things, a couple others that we have worked on, because I think it's what's led us to this point. We've helped CDC develop their own genomic capacity. 8 years ago, 9 years ago, CDC, we had more genomic capacity for public health than CDC did, just in our shop here in Flagstaff, Arizona. We've helped them grow into becoming the preeminent public health genomics entity in the world. We supported Arizona in previous pandemics, including the swine flu in 2009. And you guys haven't forgot about that one, the H1N1 outbreak, our pandemic. We found the first cases in Arizona, working with the state health department, the state laboratory. And then we've worked on biodefense projects with a whole host of three-letter agencies, both on developing new tools and technologies and also doing forensic analyses. And now we're responding to coronavirus. But before I jump into our coronavirus response, I do want to go back a little bit in time to show how we've kind of got to this point. So a little over 10 years ago, the Centers for Disease Control came to us because they didn't have any capacity to do genomic analysis for disease investigations, what we call genomic epidemiology, or commonly referred to as disease or DNA detective work. And really what we do is we sequence the genomes, so the DNA or genetic material of pathogens, and then we compare them to each other, and we build these genomic family trees, kind of what I call the ancestry.com for pathogens. And we can understand who's most closely related to each other, Where do strains come from? Which ones aren't related to each other? That's important too when doing outbreak analysis. And in this particular case, there was an outbreak of 3 people who had gotten valley fever, what everybody in Arizona should know really well. And all 3 of them had received organs from the same donor, but there was no material from the donor to test, and that's because the donor was unfortunately in Los Angeles, a homeless woman, found unresponsive, brought into the hospital, died, and then they harvested her organs and sent those out without testing for valley fever because they just weren't doing any testing for these types of fungal organisms. And then 2 people who received the organs died of valley fever, and then a third one was in ICU for a very long time. So, but there was no direct evidence because there was no samples left over from the original donor. But when we did the genome sequencing and did this family tree, we're able to show these patients all had the exact same strain of the valley fever organism. The only way that could happen is they all came from the exact same source, and their only common source was the donor. So this was the first use of genomic epidemiology for a fungal disease outbreak. And we've worked on a number of outbreaks since then. One of the other big ones was a fungal meningitis outbreak, and you guys may remember this several years back. 13,000 people were exposed to some contaminated back pain medicine, this injectable steroid for back pain, caused over 800 cases of fungal meningitis, a very serious disease, leading to 76 deaths. And in some of the patients and in some of the vials of this medicine, they found this strange fungus that doesn't infect humans normally. It's really more of a kind of a background mold, grows on plants, and somehow was infecting patients. Well, they identified that the compounding pharmacy that was making it was highly contaminated. It was really pretty gross facility, but they were also illegally distributing their medications across the country. They didn't have the license to do that from FDA, and they were breaking all sorts of rules. The CDC came to us again, and side by side, we did the genomic analysis, built that family tree, and showed that all samples coming from patients from 7 states that we looked at, and there was definitely more states involved, as well as the vials from the compounding pharmacy, all had the exact same strain of this fungus that had killed these people and made sickened a whole lot more. This was actually the largest medical product contamination case in history. And actually led to arrests and trials. I had to testify in a federal murder trial for this, using our data and explaining genomics to the jury. And in the end, these people got convicted not of murder, but of racketeering and fraud and many other things that put them away for many years because of their gross negligence. Many families lost loved ones, and lots of people suffered. A few years later, a just as serious outbreak that most people didn't know about, what has been called the cancer kid outbreak, of again another fungus killing kids in this case in Colombia and in Chile. These kids all had cancer. They were all then on chemotherapy and then taking anti-nausea drugs. So this ondansetron is an anti-nausea drug that actually pregnant women use here in the U.S. called Zofran. But in this case, it seemed to be contaminated because kids were getting infected with the same species of a fungus. And again, the CDC we worked with the WHO and CDC and others to get samples from Chile and Colombia, from the patients, from the vials, and we were able to show that again they all had the exact same strain, essentially no differences. There are very few mutations being able to see, and so we know that this was a point source outbreak, and it was this ondansetron medication that was essentially killing these kids. A very sad case, but at least we were able to find it, and they shut down that operation. And then one more example that I think is also kind of leads us closer to present day, a polio-like disease outbreak that occurred here in Phoenix, and it's actually occurred in multiple places. There was an outbreak occurring in Phoenix Children's Hospital, 11 cases of kids that looked like they had polio. We don't have polio anymore. There's only very few cases in the world. We've completely vanquished it from this side of the planet. And yet these kids were showing up with what looked like polio, and it technically called acute flaccid paralysis or acute flaccid myelitis, which is really that paralytic type disease that kids get from polio. And so we worked with the Maricopa County Public Health, the State Health Department, CDC, and others to understand this situation. But in the backdrop, there had been outbreaks of this occurring. So in a couple of years previous, in 2014, a real spike in case of these kids having this polio-like disease, and then it disappeared in 2015, and then in 2016 back again, and causing an outbreak, including the one at Phoenix Children's. And the thought is that maybe it's related to this enterovirus D68. Polio is a virus, and it's a type of enterovirus. Well, here was a new enterovirus that seemed to be associated with cases, but there was no great empirical evidence that all the cases had this virus. So that's why the state and the county came to us and CDC, and we essentially threw the genomic kitchen sink at this thing. We did every possible way to look to see, did these kids have this virus? Did they have other possible causes? I'm not going to go through any of this, but I'm going to show you kind of an ugly, this is a data slide here, but I just want to point out a couple of things. Out of these 11 cases, the CDC deemed absolutely 4 of them, those top 4, had this AFM, or acute flaccid myelitis, which was really the disease that they were looking for. We, and CDC was not able to detect the virus in them, but we were able to use the technology that we're using now for COVID-19 to essentially identify that, yes, indeed, the 3 kids that we got that were part of this AFM cluster that we were able to get the nasal pharyngeal swabs, these NP swabs that we're also using to test people now for COVID, they were positive for this enterovirus D68, and through multiple technologies that we developed, including PCR assays. And then we also identified another one of the suspect cases that CDC didn't think was part of the cluster, absolutely also had this enterovirus D68. And then one of the cases, and actually 2 of the cases, but one that was part of what CDC said was AFM, these did not have the enterovirus D68, but they had something else. In their cerebral spinal fluid, we found herpes simplex virus, and we know that that can cause neurologic disease. So we actually were able to find the causes for a couple of the cases that were not part of the polio cluster, polio-like disease, I should say, cluster, but had a different cause. Now, one of the reasons why I wanted to point this out is, so this outbreak was in 2016. In 2018, again, another outbreak. So every 2 years, it seems to be getting worse, and this virus is moving around. We don't know why it's every 2 years, but you know what? It occurs in the summer, and the summer of 2020 is now upon us, essentially, and we're actually expecting to see an outbreak of this now in our kids, and something that we're going to have to look very closely for as we are still responding to COVID-19. So here's where we jump into COVID, and I'm going to talk a bit more specifically about COVID now. And this slide here just kind of shows the timeline, the early timeline of where we jumped in. We know that we actually didn't first hear about this coronavirus until the beginning of January, in reality, early January. And coming out of China, something very alarming. I've been watching coronaviruses for a long time and worried that we would see another SARS-like virus. And that's what it looked like. Very early January, a SARS-like virus that related to other SARS-like viruses that come out of bats seemed to be spreading in China. And as soon as cases started coming out of China, we decided quickly, I want to make sure that we have tests that we can look for this in case it's needed. We don't know if it's going to be needed. Within a couple of days, the very first case showed up in Arizona after we started working on this. And that was that ASU student out of China that brought it, but there were no other subsequent cases from that for weeks. This gave us a lot of time to really build our tests, to get FDA allowance to stand up what's called a CLIA diagnostic lab, and that's a federally registered lab that allows us to do testing on patients, and put that all into play and start. And so we had the first non-state lab COVID testing lab in Arizona, up here in Flagstaff, and we've been going great guns since. And I'll talk a little bit more about that. But the testing is something that we should all kind of have a better understanding about. What does it mean when we talk about testing? There's different types of tests, and there's probably some confusion. So I'll spend a couple minutes just on this. So virus testing, antibody testing, and actual genomic analyses. So starting with the viral testing, this is what we have been doing from the beginning. This has been the most important test, because what we're doing is looking for the presence of the virus in a patient. that is the gold standard for diagnosing, that you actually can tell that the patient had the virus in it. And it's also critical for tracking the pandemic and the spread of the outbreaks locally and across the globe, to be able to detect and analyze the virus specifically. Those nasal pharyngeal swabs that I just talked about, and everybody knows those long swabs that are being used, are still the standard. They give a great sample if they're used. But now we're also starting to see other samples, and we're going to start testing just saliva-based testing, which we think holds great promise as well. And then the majority of these viral tests are what have been called PCR-based, and you've probably heard PCR being mentioned. That's essentially about the best molecular tool we can use to detect the virus. It actually looks for fragments of the virus that only occur, or fragments of the viral genetic material that only occur in this virus, no other living organism on the planet. So we've made our tests incredibly specific, so we don't get false positives, as well as incredibly sensitive, so we can detect down to just a couple, less than 5 viral molecules in a patient sample that we're testing. So incredibly sensitive and accurate. And then there's some of these newer PCR tests that are coming out, these very rapid tests you've seen on kind of national press conferences and the like. These tests are use the same technology. They're very accurate too. They lose some sensitivity. They can't detect down to those very, very low levels that we're seeing, but they can give a very rapid result within minutes to maybe an hour with some of these tests. And so those are being used in some places as well. You can't test hundreds to thousands of people at a time, but you can get a rapid response, say in a doctor's office. Then there's the antibody testing, or serologies. We've been hearing a lot about this. And so what a serology test does is it looks for the presence of antibodies in the blood. And antibodies are what your body's immune system produces when you've been exposed to a pathogen. You generate these antibodies, and then your first line of defense in case you ever get exposed again. So the antibody is a good marker if somebody's been exposed. And so this is what you usually use this type of test for, is to determine whether or not someone's been previously exposed, and maybe they have immunity. And the early indication tells us that a COVID-19 exposure does cause antibodies in most people, but we don't know, is that protective in all those people? There's some good evidence to say that it is, and will likely be for at least several months and hopefully several years. But we don't know all that for sure yet. So we don't know if a positive antibody test means that you're protected. The other thing that we don't know is that if a positive antibody test is actually a true positive, because most people were not exposed, the vast majority of us, I would say at the highest we could say is 5% exposure in some communities in Arizona. By and large, it's probably much less than that. And that means that with that low of a rate, you're going to have a lot of false positivity, meaning that we're probably almost at a 67% predictive value, meaning that 33% or maybe more of positive tests will actually be false positives and not real. But the tests are getting better. There's more exposure happening. These tests are going to become more accurate and more useful as we move forward. But they're not useful now to determine whether or not somebody should go back to work, because at the best, 95% of us will not have been exposed. And what does that mean? Only 5% of people can go back to work? That doesn't make a lot of sense. We have to use other reasons and measures to determine how people really engage and get back into society. And then there's the sequence-based testing, this genomic tracking, where we're sequencing the genetic material. In this case, it's RNA, not DNA, that the virus has. And we're able to then build that family tree, as I mentioned. This is a global tree that's been built by researchers around the world. And then we can put our Arizona genomes into this tree and see where they are. And I'll talk here in a minute about what we're able to find from this. But the whole point of doing testing is not, part of it is to give doctors information about their patients, but part of it is to understand this virus and understand this pandemic. And that's where we get really good solid data. So if we identify cases through testing, we know in Arizona, so this is the updated numbers, as of early this morning, 17,000 cases in Arizona. And we do think that the peak has or the curve has peaked and is dropping down. And I'll talk about seasonality here in a minute, and that's what all the indicators tell us. But the number of cases don't really tell us the full story. Certainly, Maricopa County, Pima County, vast majority of cases because they have the vast majority of people, Phoenix and Tucson. But the biggest problem areas has been by far the Navajo Nation in Arizona. This has been one of the worst problem areas in the entire country. Some of the highest rates of infection, 10 times the rates that we see in most other parts of the state. And thankfully, they're starting to get through the worst of it, but they still have a lot of disease and unfortunately death happening on the Navajo Nation. We can talk a little bit more about that too, if we like. One of the other metrics is looking at hospitalizations and how many people are taking up beds, and we can also see that that is significantly dropping by the day on average. So this is a good indicator of the amount of serious disease that's out there, is those that actually go to the hospital, and we're seeing fewer and fewer people in the hospital, thankfully. And one of the other great things to notice is that our healthcare system was able to absorb at least the worst of it so far. And we've never were at capacity in most of our state, except for up on the Navajo Nation, and have always been able to respond to the caseloads, which is a really good thing. Yet one last indicator is looking at deaths from COVID, and these two have to be confirmed by testing. And we can see that that has peaked and has dropped significantly as well. We're still going to have cases, we're still going to have deaths, but most importantly, we have to learn about the deaths and where the damage was from this outbreak. We look at some of these data in that middle chart at the bottom. This is telling us really a big part of the real story here, which is the people we knew who are at biggest risk for serious disease and death are the ones who did get serious disease and died. And that's the significantly elderly with chronic conditions. The fatality rates in our elderly have been astronomical. Those 65 and older with that tested positive had over an 18% fatality rate. That's off the charts. We don't see that with any other disease. However, when we look at the other end of the scale, those that are younger than 45 had well under 1%, less than 0.5% fatality rate, which is much more like influenza. So for a large chunk of the population, this acted like another influenza by and large. For those at high risk, this is an incredibly devastating disease, and we lost those that we knew we were going to, even though we did everything, I think, in our power to try to protect them. So that's kind of distressing. The other is looking at on the right-hand side, the Native American population, the fatality rates. That's actually missing some of those that are unknown at the bottom are Native American. We think it's probably even closer to 20%, maybe 18 to 20% of the fatalities in Arizona. Unfortunately, Native Americans, they make up less than 5% of our population. So much higher fatality rates in the Native American population. And again, a lot of this was the unfortunate tragedy up on the Navajo Nation. So I mentioned the real at risk. The other piece to that is a large number of these that were elderly with chronic diseases were in group living situations. This is showing us all the numbers of these types of congregate settings where there have been outbreaks. There's been cases of COVID here in Arizona. So 180 facilities that are long-term care, nursing home type facilities, and likely even more. So that makes up a good majority of these facilities in Arizona. But more importantly, almost a quarter of the cases in Maricopa County were in these long-term care facilities. This is a very small percentage of the population live in these facilities, yet make up a quarter of the cases. And then greater than 70% of the deaths in Maricopa and Pima County were associated with these facilities. That's devastating, but that's it. I mean, that is the heart of the outbreak was right there. And that's where we need to spend our time moving forward, is protecting these individuals living in these settings. And we're gonna make a huge dent in the impact of this outbreak if we can do a better job at that. I mentioned the seasonality. One of the reasons why we're pretty hopeful that the cases are really going to drop off, at least for a few months, is that Respiratory viruses just typically are seasonal. We typically see them in the winter and they drop off as soon as it starts to get warm. And that's for a number of reasons. The virus doesn't survive well in the heat or outdoors. People are outdoors more and not spreading as much virus. So this is a good indicator that other respiratory viruses will follow suit. So this is showing influenza-like. So it's a number of pathogens with looking at in this group. If we look at what COVID-19-like symptoms, so not just COVID, but those other respiratory pathogens that look like COVID, we're also seeing that those are dropping off. So that red line is the number of ED visits with people with COVID-like illness. And you can see that has now dropped down to the levels before we actually had the outbreak occurring in Arizona. So this has really dropped off. Our EDs are not, our emergency departments are not getting overrun. In fact, we're not even seeing much difference than before the outbreak started at this particular point. So this is great news. The bad news is that respiratory viruses always come back in the fall. And I do think that we will see if this does hold down to lower levels throughout the summer and in the fall, the late fall and winter, I think it's going to come back with abandon is really going to be much worse than the first wave. That's because the virus is going to already be seeded in many communities around the state and just looking for the right time and opportunity to explode. So we have to do everything we can to help prevent those that are going to die from this in the interim, keep them safe and put real protections while the rest of society tries to get back to not to normal, but at least to functioning again. And then the genomic tracking, as I mentioned, I'm almost done here, Aaron and Dean, so then we can take questions. But the genomic tracking is allowing us to ask and answer some really interesting questions, as I mentioned. And there's those Arizona cases you can see highlighted on this particular tree. And then if we zoom in on some of these branches where we know we've had cases, for example, here's a branch where there were 2 Arizona cases. We knew that these were linked to each other, but we couldn't find any other Arizona cases on this whole branch of that family tree. There's no other Arizona cases here. What's interesting is that this group is in the middle of this branches that are surrounded in blue. I don't know if you can see my arrow, but this group here is an Australian population. So Australia and New Zealand predominantly, and likely there was some connection in one of these cases, Arizona cases, a healthcare worker may have been exposed to somebody who traveled from or visited Australia and brought the virus back. But it's even more complex than that, because if we look further down the branches of this tree, so these are the older populations, this whole chunk of this branch that this is part of is actually a southern US branch. So this is circulating in Georgia and South Carolina, and then somehow emerged in Australia, and then somehow came back to Arizona. And it's even more complex than that. But as we know, all roads lead to China. This original branch here comes out of Asia, Korea, and China. That before it came to the U.S. So we can really do some really interesting trace back of where strains are coming from. Another example is this one we probably heard about New York being so important as a hub for this virus, the Grand Central Station for the U.S. And in this particular case, it's true. This whole branch on the tree is really all New York, and right in there's a cluster of Arizona cases. Clearly came out of New York and ended up causing some diseases here, or some cases here in Arizona. And then one last example is something. This is just now getting really nerdy. We have a community in Arizona that we're working with very closely. They've had incredible transmission, 100% attack rates. Everybody in a households of 10 or more, everybody gets infected. Out into the jail, everybody gets infected. So it's really high attack rate, but very low fatality rate, well under 1%, even though there's a lot of high-risk people in this community. And so that outbreak we can actually see is all these that are in yellow up here they're all part of the exact same strain. It's not multiple different strains in this community. It's only one that we've seen so far. And what's interesting is that this branch for this that leads to this outbreak is has a mutation in it, and that mutation is only seen in this particular outbreak. When we compare to the rest, and I should say almost only, we compare to the rest of the 25,000 genomes around the world, we've seen it only twice before, and it's not led to an outbreak strain, kind of fizzled out. But in this particular case, the virus is acting a little bit different. It's not as deadly. It seems to be potentially more transmissible. And so there may be real reasons that this mutation may actually be leading to some causes of these changes. So the kind of things that we as genomicists really want to understand about these viruses. One last thing I got to point out here is our testing partners. We at TGen, we've not been trying to be the biggest commercial testing lab out there. That's for the LabCorps in the Northwest. What we've been trying to do is have the biggest impact possible. And so our partners, our public health partners and clinical partners that we've worked with for years, where we see some of the most at-risk or disadvantaged communities, certainly many of the county health departments, but that means that we're working then in those counties, we're working with shelters, jails, medical examiners, the nursing homes, maternity wards, women who are about to be induced or have C-sections. We're testing them before they have before they give birth. Stand-up clinics. We helped set up the first stand-up clinic in Arizona, and is still going here in Flagstaff. A number of the tribes, as I've mentioned, and tribal health entities around the state, community health centers, medical centers, inpatient psychiatric centers. A lot of these are homeless. They get committed, and then outbreaks can devastate those, so we're working there. And then surgical centers, people are now trying to get back to surgery. They need to be tested before they have their elective surgery. And then, of course, first responders are critical to us too, police and sheriff and other first responders, and we've been testing them, especially after they've been exposed to people that they've either been saving or needing to arrest. So that's it. My partner in crime down there at the bottom, Dr. Jeff Trent, who's our president and research director at TGen, he and I have been working on this from the very beginning, but it's really not us. It is this amazing team at TGen. We've doubled our staff, but the staff that we had of 35 originally all jumped in. No questions asked. Everybody jumped into the fight. We repurposed the building. We repurposed our scientists. We've been on full COVID-19 response since February, but really since March, since we've been really doing most of our testing. And it's been essentially a 24/7 operation. And I could not be more proud to work with the folks at TGen, not just TGen North, but a lot of folks down at headquarters, our administration, our purchasing, our legal departments. Everybody's been all in, and it's been great to work with. And with that, I'll turn it back over to you, Erin.
Thanks, Dave. That was really a wonderful presentation. I'm delighted that the group got to hear a little bit about TGen North as a whole, and we're so focused on COVID, and I want to continue to address that, but I think for the ambassadors in our community to better understand the importance of the pathogen genomics division as a whole is really important. So thank you for spending some time on that this morning as well. We have a number of questions. Some were coming in while you were talking. So I'm going to start with one that came in prior, and then we'll move to some of the ones that came through this morning. There was a question, you talked about antibodies, and there was a question about, with the necessary acknowledgement that we don't yet know whether the COVID antibodies work like a typical antibody in terms of immunity to the strain. If they do grant the manner of immunity, how would we expect that immune person to still be COVID vector in terms of droplets, coughing, talking, singing? And putting it another way, if they recovered from COVID, could they still be
infectious,
transferring that? Does that make sense? Okay.
Yeah, thanks, Erin. So I think the question here is, will people still be infectious, and can people be reinfected? So what we're learning here is that, during the course of disease, you can generate a very specific type of antibody, what we call IgM, as you're still infected. So it's usually about 5 to 6 days after you show symptoms, your body's now producing these antibodies. And these antibodies are helping to direct your immune system's response to target specifically only those cells infected with this virus. That antibody is not it's like the instant response antibody, and that lasts for typically a few weeks to and maybe a month or more. But it's replaced by a different type of antibody, what we call the IgG antibody, and that antibody can last now for months, and in some cases, many cases, years. And so that IgG antibody typically doesn't show up on tests until after somebody's already gone through the course of disease. They're no longer have the virus. They're no longer infectious. So some antibodies we can detect while people are still infected and they're still having an active disease. And then other antibodies we detect after that they've recovered. And by having these antibodies, we do believe that we're going to have some level of protection. That IgG antibody will help prevent you from getting reinfected at least for several months. It's just not been long enough for us to know whether or not it's going to protect you for multiple years, like a lot of other antibodies do for different pathogens. Does that answer the question?
That does. Thank you very much. Another question, you talked about the people in our community that are at higher risk and really needing to protect and safeguard those in the future, especially with what we anticipate to be around 2 and a stronger surgence of COVID. Fred Pecos asked, you know, if in the future there was a reality of unlimited testing available, what would an ideal testing protocol look like in an assisted living facility? Would there be a type of test used or frequency, contact tracing, quarantine, et cetera? How do we protect that community of people?
Yeah, that is a great question, because I think we knew that was the community that was at most risk. We shut down society and try to prevent spread, and certainly at these long-term care facilities, and have done a lot of testing, and we still weren't able to stop the spread. So there's one thing about viruses: they're like water; they will find the cracks in the system. They'll find a way through, and so what we ought to do is try to work really hard to make sure that we're not allowing the virus to get introduced into these facilities. And so we screen anybody that's going into a facility, and obviously test anybody who's at a facility. So if we don't have anybody new coming in, testing people, I think, pretty regularly is feasible. Maybe something like every 2 weeks or once a week. And that's because, the testing discomfort with the swabs doesn't make much sense, and it does cost a fair bit of money to do that. However, we are getting closer to these kind of handheld tests, these very rapid tests, and we're seeing that saliva may actually be a good sample to use. We still have some validation work on that, but others have done some great work. And so maybe easier to collect samples and use some of these smaller, almost like the pregnancy type tests, that'll give a good indication if the virus is present in a facility. And that can be done almost daily. And for relatively inexpensive amounts. So the testing is becoming cheaper and maybe even easier to do. I think that's going to be important. And I think the absolute lockdown on visitors, we just can't have it. We need to have you could have the visitors through the glass and all that kind of thing, but the face-to-face sharing the same air, this is what's killing, unfortunately, these people. So I think a lot more engineering needs to be done in these facilities to ensure that people aren't being exposed, as well as really, really strict policies. Until we have a vaccine in place and until we have a herd immunity, they're going to have to be shut-ins and really isolated from society. Otherwise, we're going to lose them.
Gosh, I feel like that could span a much larger conversation, because in the beginning we were talking about what being socially distanced, and then there was this review of conversation around it's not really socially distanced. You want to stay connected to people, but it's the physically distanced. And I know firsthand, for those of us who have loved ones, how hard that is to be isolated, essentially. But another day for that to be a conversation. A question that we had was There was a lot of talk about regarding a rapid development of a vaccine. How realistic do we think that is to have a vaccine by the end of the year? And, you know, how do multiple mutations affect the development of a vaccine?
Those are both great questions, and certainly on top of everybody's mind, because that's what we want as a vaccine. And I think realistically, we will see some great vaccine candidates come out through the trials that are happening right now. So there are well over 100 different vaccines that are being tested right now. Many of them are actually in phase 1 and phase 2 trials, where we test both the safety of the vaccine as well as then the efficacy, or how effective the vaccine is at preventing disease. Those take a while, unfortunately, because you have to measure that effectiveness in a real world situation, and monitoring whether or not people get infected after being vaccinated. And that can take weeks to months. So I think it's not realistic to think that, even though we have good vaccine candidates now, that anything's going to be available to be approved and being produced until the end of the year. I think manufacturing, the logistics around manufacturing and distribution is enormous, as well as the politics. And we're going to see a lot of these discussions over the coming months. Who gets it? How do they get it? Does US get it first? All of these things are going to bubble up. But my best hope is that by the beginning of next year, we will actually have some manufactured vaccine that is starting to get out to those groups that need it most. And that is those where we can build protection around the people that are going to suffer the most, the caregivers and these individuals. Even if the vaccine doesn't work great in them, you got to build a wall around them, and that's who really needs it first. Then our healthcare workers and our first responders, and then you can see from there it starts to roll out. So it could be many, many months, even after the first vaccines come out, before people actually can get vaccinated. But my hope is early next year that process starts. And then the other half of that question, the other half of that question was about mutations. We definitely are seeing that the virus is evolving, it is mutating, and that's because it's a virus. All living things mutate and evolve. However, we are watching every one of these mutations closely. It does seem that it's possible that we get some mutations that may help a virus escape a vaccine. But my guess is we're probably going to need to see maybe even a couple of years of mutations develop that a vaccine that's developed now won't work. And that makes it actually a lot like the influenza virus, also an RNA virus that mutates about as quickly. These things change over time, especially as they move around the globe. So if we do get a vaccine, it's most likely that vaccine will have to be re-updated every couple of years. And maybe the virus finally fizzles out by then, or maybe it's just now a permanent part of the human species.
Thanks, Dave. Well, being respectful of the time, we're nearing the hour and we went a little bit over, but I want to say to the group, there's a lot of really good questions in the chat that we're not able to get to all of them. So if somebody got a question that they're looking for an answer to, please contact Dean or I offline. And if we have the answer, we'll give it. And if not, we'll work with Dave and team to get you the answer. And before we close out, Dave, the last question, and I think you have kind of touched on this throughout, but what are the things that should be done to better prepare people for COVID returning, or this potentially? I think we're not at a place where it's going to continually get worse right now. You've shown that it's kind of peaked. So what are the things that should be done to better prepare for COVID returning in the fall and winter?
Sure, and actually to not just prepare for that, but also to start to re-engage with society appropriately now. And so one is, even though the amount of cases are dropping and disease is dropping and we're re-engaging, it's still up to us to do our best to limit the amount of transmission in the community. Even though we want to develop more herd immunity, we've shown that we can't protect those most vulnerable, even when we're in full lockdown. And so they're still going to be at high risk. We still have to do our part. So public health is on all of us. It's not just a government agency, it's us. It's us doing the social or the physical distancing. It's the hand sanitizing and hand washing, the not crowding into spaces, not packing into a bar on Mill Avenue in Tempe, not doing those things that really put others at risk. We can still re-engage and be safe about that. I think some of us run businesses and thinking about that, protecting employees, protecting customers. I think what we do now is we help to kind of adapt to a new normal so that we can really firmly have these policies in place that we're following now that are going to help us during the next wave. We also need to have these plans in place about, okay, we may have to move back and forth from being out in public to just being locked away again and then out. And so having adaptability and that type of resilience is the kind of thing that we need to build in to the workplace and to the schools and into society in general. So I think just thinking about it from that perspective is going to help us be better prepared for what is likely coming.
Great. I think that's a really good way for us to end the call today and the presentation. Thank you, Dave, for just having a very honest and direct conversation with us and giving us this update. And we look forward to being able to communicate with the ambassadors in our community about the work that you and the team are doing. And depending, on feedback and, what transpires with COVID going forward, we may look to do another update with the ambassadors as well. I know they so value and appreciate your feedback and just your evaluation of COVID altogether.
Yeah, I'd be happy to do that, Erin. It's been an absolute pleasure this morning, and I'll look for other questions if you pass them along and try to get to them, and hopefully we can just kind of carry these messages forward because there's so much misinformation or just lack of understanding, and I think everybody here can help improve that.
Yep, absolutely. Thank you so much.
You bet. Thank you.
Bye, everyone.